Hello, everyone. Good morning, good afternoon, and good evening. Welcome again to the GIS, to the Dental Olympics. We hope that you're as mesmerized as we are and as excited as we are from what we're trying to get you from every single corner around the world. We're trying to give all different point of views and speakers and lecturers from every corner to come in and blend in all the information, and hopefully it can open up a new wide way of thinking. Today we have our host, Dr. Sandeep from India. Welcome.
Good
And
evening.
Dr. Amr Ekram from Egypt. So today we have India and Egypt combined. And we had a little bit of a problem just with the camera for Dr. Amr. So he's going to be sharing his presentation on the screen. And if it got live at some point, we'll be happy to see you, Dr. Amr. I'm going to introduce Dr. Sandeep very quick. He's a good friend of mine by now, and I'm going to read his bio very quick for you. And we're honored to have you, Doc, always.
Little.
Dr. Sandeep Singh is the president and the international board member of WAUPS, Southeast Asia, an organization of ultrasonic piezoelectrical bone surgery and growth factors. As Director of Dental Health Sciences, Schwartz University, Allahabad, India, he works to develop and promote piezoelectric bone surgery, growth factors, and on organizing conferences and lectures and workshops on vertical and horizontal 3D bone augmentations procedures. Dr. Singh graduated in dentistry from Amravati University, India, completed his residency at AIIMS, New Delhi, and his mastership in implantology at UCLA. He's also a certified trainer for endodontic procedures from Melfair Institute, Dentsply, Sirona, Switzerland. Welcome, Dr. Sandeep. Welcome, Dr. Amr. And we're excited about today, as always. And Dr. Sandeep, you'll take it from here to introduce Dr. Amr.
Thanks, my dear friend Joseph. It was wonderful. Thank you so much for introducing me. And as a board member for Global Summit, I have taken this responsibility to host few of our speakers. And today here we have Dr. Amr Ekram from Egypt, and he is an oral and maxillofacial surgeon, and he has a consultancy in Egypt, and he is a certified DHA implantologist in Dubai, UAE. He graduated in the year 2000 and then had his master's and PhD degree from Cairo University. He's currently the president of Digital Dentistry Society, DDS, in the Middle East sector. And he's one of the pioneers to start in the field of digital dentistry in the Middle East, and he has participated in as a speaker in many national and international conferences. And most recent are the IDDA Global Conference, DDS Global Conference in Germany, EDSIC in Egypt, and AEEDC in EDEC in Dubai in the past couple of years. And his private practice includes many offices all over Egypt that provide CBCT imaging and digital solutions, mainly surgical guides, orthodontic wafers, custom implants, which I believe we'll have a preview onto that, the custom implants, which will be quite interesting. And in addition, he has an instructor in many private courses and workshops in the digital dentistry subject and implantology. So without taking much of our time, because we had some technical glitches before that, and unfortunately, we are not going to have the live view of Dr. Amir, but his presentation is going to be there, and then this picture is here. And welcome, Dr. Amr Ekram, and on our platform. And I believe today we are going to have a wonderful session on to digital workflow in the dental practice, day-to-day practice.
Thank you very much. Shall I start now?
Yeah.
Okay, thank you. Okay. Today's lecture is about taking computer-guided surgery beyond the limits. We are not going to discuss a simple, easy case of putting an implant with a surgical guide. We are going to go far more beyond that. So, let's give a brief introduction about the difference between the conventional way of treatment and the digital way of treatment. In the conventional way of treatment, fortunately you have the patient. You can see his gums, his gingiva, teeth, lips, smile, face. You just need an X-ray to complete the information about the roots and the bone, air spaces, and so. It's a bit easy to start doing treatment. But in case of you want to do more accurate treatment, you have to go for the digital solution. In the digital solution, you must have the patient as well, but in the digital form. So to have a conventional way of treatment, you must have a real patient. To have a digital workflow, you must have the digital patient. So unfortunately, there is not a single modality up to this moment that can get you every little bit of information that you want. You can't get the gingiva, bone, and teeth and face all in one scan, whether it's a CBCT, an optical scan, ultrasound, MRI, nothing gets you the full information. So we must do what we call the digital or virtual patient or the digital assembly. It's by taking every piece of the patient or every part of the patient. You can get it with a special modality. For example, here we have the CBCT to get the bone, we have the optical scan to get the gingiva and the teeth, and we have a photo or a facial scan to get the face. And from there, we can start our treatment planning. Second rule in digital dentistry is that you always have to start with the prosthesis. You do not start with the bone ever. So in this case, as we see, this is a bone-driven plan, meaning that we determined the best parts of bone and we placed implants. This is not right. Okay, as you can see, if we can try to put the prosthesis after, the implants are placed in the embrasions and contacts, and this is not the right choice to do. We always start with the prosthesis like this, and we choose the implant position afterwards. So let's start our cases. Our first case is an interesting case. It's a digitally customized CAD/CAM bone block grafting, milled with implant placement and immediate loading. So this is a middle-aged patient, male patient. He had a previous implant inserted in the upper central incisor, and unfortunately the implant failed. We have here a horizontal bone defect and also a vertical bone defect. So this implant had to be taken out, okay? And here we can see the patient smile and the aesthetic zone, and we can see the defect in the upper central incisor region. So starting the plan, we did digital planning by registration of the models to the CBCT in occlusion. Okay, we did a prosthetic plan, placed the implant in the best position regarding the restoration, and we designed a PMMA crown. We don't need to take impressions. We are supposed to place the implant and then place the crown after surgery immediately without taking any impressions. So this depends that you must have a library in the software that can facilitate that. We put the implant beyond the bone. We left about a few millimeters because to augment the vertical defect. We can see here, this is the crown, and this is the implant placed. You can see the direction of the screw is palatal. And here we designed the surgical guide for implant placement. Then we designed the bone graft, okay, and make a hole. We made a hole in the at the top to allow implant to be placed and to be surrounded by the bone. You can see here, this is a CAD/CAM milling of bone, okay, and this is the digital planning. As we can see here, we did the plan based on the prosthesis that was already present in the patient's mouth. Okay, and we milled the bone block according to this plan. So this is the bone block after milling. Now we have our implant, our surgical guide, our PMMA crown for immediate loading, and our bone graft, and we are ready to go. We started by checking the guide in the patient's mouth, then raising a flap, a full mucoperiosteal flap. Then we started to place the guide once again after raising the flap. As you can see here, this is the flap. Okay. So after this, we had to check for the bone graft before placing the implant. We had to make sure everything is okay, and then we seated the guide again and started drilling for implant placement. As you can see here, this is the guided surgery, and this is on the left. You can see the drilling, and on the right you can see the implant insertion through the guide. Okay, so we had the implant placed, then we placed the bone graft. We put some particulate bone and then covered with a membrane, because particulate bone, it has a small particle size. It can initiate better osteosynthesis, faster, I mean, not better, faster, and fill the gaps if any are present. Then we covered this with a membrane, and also we had to take a palatal flap to close the defect, and this is the fixation of the bone graft in place using a screw. Also, the screw was predetermined. The position of the screw was predetermined before surgery, so as not to hit or collide with the implant during placement. So everything was pre-planned before starting anything. So this is suturing. We had to take a connective tissue graft from the palate here. Okay. So this is the connective tissue graft. And place it and suture it then. We sutured and we placed the PMMA crown immediately. So we did a bone graft, we did an implant placement, guided, and we did an immediate loading, all pre-planned digitally. You can see this is the patient, and this is the whole case. This is our team. I always work in team. Teamwork is very important. This is the bone defect here. We can see it in the CBCT. You can see the implant position, placed beyond bone for vertical augmentation, surgical guide. Here is the bone graft designed. Okay. This is the digital bone graft. This is the CAD/CAM milling of the bone graft. And this is the final bone graft after milling. This is where we designed the superstructure, the PMMA crown, for immediate loading. And this is the final crown for temporization. Of course, this is for temporization. Place the surgical guide, did the incision. Okay. And this is the bone defect, surgical guide placed, and guided surgery, placing the implant. And this is the bone graft placed in place. We can see here, it's precise. Okay, you can see all the photos. We put the membrane and we placed the particulate bone. Okay, let's go fast forward. Finally, this is the position. We sutured, and here is the X-ray, and here is the final temporary crown. So, next case. Next case is a stackable guide. I'm sorry for this. Okay. Next case is using the stackable guide for immediate loading. So this case, a patient came, a female patient presented with a full arch mobile teeth and periodontally with periodontal defects. Okay, and good bone quality. So about was D2 bone. We had an optical scan of the lower cast, and we did some virtual extraction, did the registration for occlusion, put it on the virtual articulator, and we designed a mock-up or wax-up. We did the registration with the cone beam CT to both casts, the one with the vertical, with the tooth, virtual extraction, and the one with the teeth present. Here we can see we did a prosthetic-driven plan and using all-on-4 concept. We did what we call a foundation guide or a fixation guide. This is a guide that has a lock. The lock serves to place multiple stackable guides to use it in different parts in the surgery. In order to place this foundation guide correctly, we had to do a reference guide based on the occlusion of teeth. So we can place it right, then check. We can then check the occlusion, place the surgical guide, and then make a pickup for the final prosthesis, of course, temporary prosthesis. We can see here. So we have a reference guide to fix the foundation guide or fixation guide. We have here an occlusion guide, then a surgical guide, then the immediate temporary restoration. Let's see the workflow here. This is designing a fixation guide, and this is the reference guide locked to it. Okay, as you can see here, to be able to place it in the right position, use the fixation pins, and then do our extraction, check the occlusion, and finally do the surgical drilling, and then placing the implant abutments and do our pickup. And of course, we had to remove all these locks. Okay. So to summarize, this is the patient, this is the reference guide, and we use it to place the foundation guide. We then check the occlusion, we put the surgical guide and place the implants, and finally we do our pickup. You can see here in this video. Okay. First of all, we placed the reference guide. We used the we placed the foundation guide. Used the reference guide occlusally to check that the position is fine. And then we did the fixation. And we did the extraction while the guide is still in place. As you can see here. Okay, then we put the occlusion guide to check that we are on the right track. We wanted to make sure that we are on the right track, okay? Then we placed the implant surgical guide. And we started drilling for the implant placement. Okay. After this, we can do the implant insertion through the guide, and then we can place our multi-unit abutments and do our pickup, as you can see here. Placing the multi-unit abutment, and we then connect the multi-unit abutment with temporary abutments, of course, to be able to do the pickup. Okay. So this is where we place the pickup. We place the restorative material composite to make the pickup, and here we remove the locks, and now you can see the patient closing her mouth with not a single premature contact and immediate temporary provisional restoration. Next case is about computer-guided ridge splitting. The idea is that we want to make ridge splitting and put simultaneous implants at the same time. So let's the key here is to make the cast, to make this block of the cast and draw the guide all around it to have a slit here where we can do the splitting. The problem with ridge splitting guides is that after splitting, the ridge modifies its shape. You cannot place a guide like this one because the ridge will be expanded buccally. So we cannot use a simultaneous implant placement unless we do an open guide from the buccal side, because we don't know the ridge splitting. We don't know how it will, the guide will block the splitting. So we had to make it open from the buccal side like this one to be able to place an implant. So let's see our case. Okay. This is our case, simple one. We need to do ridge splitting here. The ridge here is 3.3 millimeters. We decided to make ridge splitting. We did a prosthetic plan based on the crown, of course. We always start with the prosthesis. Then we did a plan for the splitting based on bone, not the prosthesis. We are going to split the ridge from the center of the bone, and we did this block that will make a slit at the end, like this. We modified the cast here with this block. We designed the guide, and then we have the guide with a slit where we can do the splitting. So this is the incision, and this is using the piezotome through the slit for ridge splitting. We then did the drilling, and we have the guide open in the buccal flange. We put it, and then we finally placed the implant. And this is pre-operative. This is post-operative. We have here from 3.3 millimeters to 6.7. We did a surgical guide for implant placement, and of course a surgical guide for ridge splitting. I mean, 2 guides. And this is the final restoration. A similar case, you can see just the idea. We have this. You can see measurements is about 3 millimeters, 4 millimeters. We want to place larger implants in this area. We did the planning according to the prosthesis, not the ridge. And then we did the planning for the splitting according to bone. We did the block. Again, we have our splitting guide here, and we can do the surgical guide here with open flange to accommodate for the split ridge. You can find here, this is the ridge splitting guide, and this is the implant guide. And this is post-operative also. We have a 3 millimeter gain in bone after placement of the implant finally. One more case is a socket shield guided surgery for implant placement. Socket shield means that we have to place, we leave a part of the buccal root or facial root, and we place the implant lingual to it or palatal. So we have this patient, he had a crack here, socket type 1. So we did a root separation guide here, just for root separation. This is not an implant, this is just the direction of root separation. Okay, as we can see here, planned by the COM-BEAM CT, we designed a first guide for splitting, not splitting, for division of the root division. Okay, as we can see here. And we did the surgical guide just for the pilot drill to dissect the root from the midline till the apex. Okay, as you can see here. So this is the first guide. This guide is for root splitting. Then we did an implant surgical guide based on the prosthesis and directed palatal to gain primary stability. As we can see here, the implant is placed palatal according to the prosthesis. And this is the final guide. You can see here. You can see the screw palatal based on the prosthetic plan. Okay. Then we did the socket shield surgery. As we can see here, this is the first guide. This guide is only used to separate the root, to separate the buccal root part from the palatal root part. Okay. So we can see this is a narrow drill, a pilot drill, just to make the area of separation. Okay, and we have the root separated here, as you can see, and we left the buccal part of the root to act as a socket shield, what we call partial extraction therapy. Implant surgery. We have designed another guide for the implant surgery, for guided implant placement, as we can see here. Okay, and implant placement insertion through the guide. Okay, and there we have the post-operative CBCT, and you can see the root here and the implant placed palatal. We also did immediate loading. This case, same method as before. Okay, this is at the time of surgery. Of course, the patient had some fluorosis, and so that and some bad restorations that would have been taken care of later. Okay. As we can see here, also my team. This is the first guide to make the root separation. Okay. And this is the root separated, segmented. This is the surgical guide for implant placement. It's a conventional treatment plan afterwards. You just need to make a guided drilling and place an implant and do the immediate loading. Okay. And this is the final implant placement. And an immediate loading, screw retained PMMA crown, of course, immediate temporization. Okay, as we can see here. Our last case here is a nice case of a foreign body removed by computer-guided surgery. We had a fully edentulous patient complaining of pain in the upper right quadrant. There are no teeth at all. After making a CBCT, we found that foreign body. This was the cause of pain. We couldn't find any other source of pain. So to remove such a foreign body, definitely we'll need an open sinus lifting, because trying to get this foreign body from a crestal approach will push it inside the sinus. So what we did was, thinking, we thought out of the box. We measured the area of we measured the length of the foreign body and the length of the ridge, and we decided to place a Trefeinberg to get the foreign body out without having to open a lateral window. So we designed a bone-supported surgical guide, and we calculated the length that the Trefeinberg has to go to get the foreign body, just to get it. And as we can see here, this is a periapical radiograph during surgery. And we got the bone and we got the foreign body, as you can see. And then we replaced the bone part again. This is the fusion pre and post. We placed the bone part again as if it's a bone graft. And this is pre-operative and this is post-operative. You see it's almost intact. We did not have to open a lateral window. The bone is almost intact, and we got out the foreign body. Thank you very much for the presentation. I'm so sorry about the technical problems that happened, but I hope that the lecture was nice and you can get some new ideas from this.
Yeah, Dr. Ekram, it was wonderful because digital is the in thing these days, everybody. But what do you think about that those who should start it, those who have done, those who have a great knack of surgery and they have an experience in implantology, then only they should shift down to digital part of the implant dentistry, or
Yes, continue, Kim. I'm sorry.
yeah, or it should because I have seen many of the companies, they tell the dental surgeons that, like, new ones, those who have not much of experience in surgical procedures and implant surgeries, that you just give me a CBCT files, DICOM files, and then we will create a guide for you, and then you just need not do anything. You just place the implant. But I don't think it's like that, because you need to know sometimes there is there's a lot of problem, and there is a situation that you have to go for a GPR, you have to go for many soft tissue, hard tissue augmentation procedure. So what do you say about this?
Okay, to start
Can you
doing
hear me?
digital work,
Yeah,
planning digital workflow, you must first learn how to make it conventional. What if the guide breaks? What if you lose a sleeve? What if the guide doesn't fit
yeah,
inside the patient's mouth? What will you do?
yeah,
Besides, you have to do the complications of the original surgery to be able to manage. And some people may think that guided surgery means a flapless surgery, and this is not true. Sometimes we
yeah,
open a flap. I
yeah,
showed some cases. You have to open a flap and put the guide. Sometimes not, but it's not a rule that guided surgery is compared to a flapless surgery. So you have to learn the conventional way of treatment, and then go to the advanced digital planning and treatment also.
okay. Now, it's a wonderful concept that, as you showed us, that you can mill block bone block that can be milled by you can design it, plan it out, and then there is a printing kind of thing or milling kind of thing.
It was milling.
So it was a milling, and
Yes.
you so what kind of block you prefer? Because is it a xenogenic block, or is it a allogenic block? What kind of bone material you are?
Allograft. Of course, allograft is always the best. Of course, autogenous is the best, but we cannot mill autogenous, so
Yeah,
we shift
yeah.
for the best, which is allograft.
Yeah, but don't you think that when you are using a allograft, it's comparatively the scaffold part is very not very good, so it resolves faster. So when you are placing the guided, I mean, like the printed material for a severe defect, do you advise to go for a layer of scaffold on top of it, like xenogenic graft material, because then resorption will be a big trouble.
Yes, first of all, this was a corticocancellous graft. It was not a cancellous graft only, so it's a
Okay.
corticocancellous graft. Also
Yeah.
used particulate bone and a membrane, as you said. So yes, of course, we did this to cover all the parts. We did not want to go through any failure after already having a failed implant. So
Yeah.
you are right. Yes, absolutely.
Yeah, because I do a lot of hard and soft tissue augmentation. So when I have to use a composite graft material, or when I am using a single graft material, uh, then then either it's like a Kuri, where you are getting a cortical plates which will not resolve so fast, or else when you are creating a scaffold, it is very important that what kind of bone material. So I believe, along with the guided surgery, people have these considerations also. And
Yeah.
second thing which was very interesting, because I recently hosted Dr. Attila Bodrogi, you must be knowing from Hungary. He does a lot of he's a dental XP expert also, and he does a lot of socket shield technique, and very soon Miltiades from Greece, and Dr. Snezhana Paul, and then Dr. Howie Gluckman. So
Yes.
I got a chance to host them, and with Attila, my last question was that are you doing some guided surgery into socket shield technique?
Yes, I'm
And
doing. Yes, you will continue.
yeah, please go ahead.
Yeah. Yes, I'm doing guided surgery for socket shield because the root is difficult to separate. Sometimes the apex is very near to the bone, and the
Yeah.
perforation is very easy. So you want to make sure that you are controlling your depth as well as your direction.
Hmm.
But it's not a must. But if you can make your life easier with a guided surgery, it will be nice. But it's not a must at all. This is not the standard protocol to do a socket shield.
Yeah, getting accustomed with a guided surgery, it is very important because do you prefer this pin fixation also? If you are doing a single tooth, if you have created a single tooth guide, uh, uh, you love to place it on take the support from the adjacent tooth, and but if it is a full mouth, then definitely you must be using a lot of pin support for that fixation of this guide.
Okay, if I have a free end saddle, I am using one pin for each saddle. If I have
Okay.
a full arch, I am using at least 3 pins. If I'm going to do immediate loading like the stackable guides, at least 5 pins to make sure the guide does not move at all.
Okay, okay, okay. That's great because I got a chance to host Dr. Scott Gans, and he came up with a because when I met him in one of the international congress where we were in Amsterdam, he showed us a guide, which is like wonderful thing that it's a dual purpose where it has a precise window for sinus where you can see the CBCT and accordingly you create that area that where and exactly which place you have to create the window on the lateral sinus augmentation. And side by side at the crestal part, it had a accuracy for placing your implants also. So it's very kind of dual one, which was wonderful.
Yes, I did this guide 2, 3 times. It was wonderful, but I didn't show it today. I had
Mm.
a couple of more tricks, but the time I did those cases, I presented those cases according to the time. But yes, it's a wonderful guide that you open your sinus lifting and place implant simultaneously. Surgical guide makes you feel comfortable, not worried. You're sure that you are not doing something horrible. Okay.
Yeah, definitely. That is wonderful thing because when you're using a guide like in this sinus surgery with a lateral approach, that helps in retracting the soft tissue also. So,
Yes.
yeah, please, you were saying something.
No, yes, it helps, but you will have to open a very good flap.
I know. It is like that, but then it is one of the things. But now, please tell me where and when, where you use these uh, bone level guides, and sometimes do you use the tissue level guides also when you have adequate bone or something? What is the criteria?
If I'm going to do, for example, GBR or bone grafting, and I have no teeth, it's better to do a bone supported guide, of course. Or sometimes I use a mucosa supported, do the pilot drilling, and just get the guide aside and start conventional way of treatment.
Okay.
So it depends on the case, but most of the time the guides are not bone supported, especially in the maxilla, because cone beam CT in the maxilla is not very good. Okay, so I
Okay.
prefer using CT scan in the maxilla.
Okay. Okay. No, no. So you mean to say that you prefer using those tissue supported guides when you have adequate bone and you have a CBCT and there is not much of anything else to do. So the pilot drilling with the to locate the exact position and then go manually. This is what you say.
Yes, exactly. Yes.
Okay. Uh, Anything you would like to tell, especially about the guided surgeries to our um, the audience there? Any message that
Yes.
what they should keep considerations?
Yes. First of all, as any dental procedure, you have to start with simple cases. Do not start with a full arch case. start with a nice, easy case with good bone and minimal risk factors. And then you can take it up to the next level. Don't start with full arch cases unless you master guided surgery and you know all the pitfalls of guided surgery. Then you can start taking this up.
Thank you so much, Dr. Amr, for your wonderful presentation and discussion. And we are it was really unfortunate that you were not live with us with your video not working. But thank you so much for being with us on the Global Summit platform. And from India, me and my team and everybody wishes you a happy Eid, which is coming down very soon. And in the holy month of Ramadan, I think it is just nearby, few more days.
Yes,
So,
exactly.
Thank
you
so
very much, and very happy, and congratulations on the 1 million views. It's historic.
Dr. Amr, thank you very much. It was an honor and a pleasure to have you, and you open our eyes a lot about bone milling. That's the future that we're waiting for, and accuracy and all the techniques coming behind it as well. Dr. Ekram, it was an honor. Thank you.
Thank you very much. Have a nice day.
Thank you.
Yeah.
Dr. Deep.
Yeah. Thanks, Joseph, and we wish you a universal greeting now. Everybody is doing no shaking hands, no hugging. It's a namaste.
You an emotional
namaste. It's namaste.
Namaste. We'll see you soon.
Yeah. Okay.
Thank you, guys.
Bye-bye. Take care.
Bye-bye.
Yeah.